Every single day, your body produces up to 1.5 liters of a highly specialized fluid. It flows continuously through a massive microscopic network of branching organic channels. This is the human salivary exocrine system. This fluid functions as an active chemical baseline for the oral cavity, initiating carbohydrate digestion through amylase, an enzyme that breaks down starches, while buffering pH levels and deploying localized immunity through immunoglobulin A and antibacterial lysozymes. This 3D model reveals the major gland pairs driving output: the parotid in blue, submandibular in green, and sublingual in yellow. Hundreds of minor glands, buccal, labial, palatine, lingual, scatter across the mouth, but clinical diagnostics primarily focus on these major pairs. This entire secretory network operates under the control of the autonomic nervous system. Parasympathetic stimulation triggers a large volume of watery saliva, typically in response to the smell or taste of food. Sympathetic stimulation, on the other hand, produces a restricted amount of thick, viscous saliva. When this system fails, whether through obstruction, infection, or tumor, the clinical presentation is heavily influenced by the gland's specific ductal anatomy and neural pathways. Let's look closely at the structural anatomy of this model, starting with the largest of the major glands, the parotid. Located below and in front of the ear, and weighing between 15 and 30 grams, it sits precisely over the jawline. The parotid gland has a specific secretory profile, producing an entirely serous or watery saliva that is densely packed with enzymes. To deliver this fluid, the parotid relies on a single physical pathway known as Stenson's duct, routing across the cheek. Driving production is its neural supply, the glossopharyngeal nerve, cranial nerve 9, acting as its parasympathetic driver. Shifting focus downward on our diagram, we locate the submandibular gland, tucked directly below the mandible, or lower jaw. While it has less physical mass than the parotid, the submandibular gland is the workhorse of the system, producing 65 to 70% of total daily saliva. It also features a mixed secretory profile, meaning it produces a combination of both thin serous fluid and thick mucus. This high-volume, mixed secretion travels up to the floor of the mouth through its own dedicated channel, explicitly named Wharton's duct. And instead of cranial nerve 9, it receives its neural supply from the facial nerve, specifically routing through the chorda tympani branch. Memorizing these distinct structural pairs, Stenson's duct and cranial nerve 9 for the parotid, versus Wharton's duct and the facial nerve for the submandibular, is the foundational step for accurately diagnosing localized facial pain and swelling. Finally, we reach the smallest of the three major pairs, the sublingual gland, which sits directly under the tongue. As we look under the tongue in this diagram, notice the unique ductal architecture. Unlike the single main ducts of the parotid and submandibular glands, the sublingual gland relies on dozens of tiny short pathways, called the ravinous ducts. Because its primary function is the physical lubrication of the oral cavity, it produces almost exclusively thick, mucus saliva. This microscopic diagram illustrates why these glands produce varying consistencies of saliva. The difference lies in their secretory units, called acini. On the left, serous acini produce watery saliva packed with digestive enzymes. These are the predominant secretory units found inside the parotid gland. On the right, mucus acini manufacture thick mucus for lubrication. These dominate the sublingual gland. The submandibular gland, producing that mixed secretion, contains an even distribution of both types. Structural architecture dictates where a gland sits, but the histological makeup of these acini determines the fluid it secretes and its ultimate clinical function. With that structural baseline established, we can map out specific anatomical failures, beginning with sialolithiasis, the clinical term for salivary stones forming within a duct. In this diagram of the submandibular pathway, we see Wharton's duct. Because it carries thick mixed saliva upward against gravity, it is the most common anatomical site for these calcified stones to form and block fluid flow. This creates a distinct symptom profile. Patients experience severe localized pain and swelling precisely during eating, as the act of chewing stimulates new fluid production that is immediately trapped behind the physical obstruction. Moving from calcified stones to tissue growth, salivary gland tumors can be benign or malignant, with the pleomorphic adenoma being the most common variant. It's a slow-growing, typically benign tumor that most frequently arises in the parotid gland. When these tumors develop inside the parotid gland, the local anatomy leads to a specific clinical presentation. Looking at this cross-section, an expanding mass presents as a palpable lump. As it grows, it places direct physical compression on the adjacent facial nerve pathways passing through the parotid, leading to localized facial nerve weakness. While those are localized mechanical failures, the network is also vulnerable to systemic viral infections, like mumps or viral parotitis. The mumps virus infiltrates the host's glandular tissue, attaching to healthy cells and triggering massive inflammation across the affected areas. Clinically, this presents as a systemic fever combined with extreme painful swelling of the parotid glands on both sides of the face, making chewing difficult. This viral pathology is preventable through the standard administration of the MMR vaccine. We also observe xerostomia, which is a clinical decrease in total saliva production that results in persistent dry mouth. Xerostomia represents a systemic decrease in output, triggered by targeted radiation therapy, specific pharmaceutical medications, severe systemic dehydration, or underlying autoimmune conditions. By isolating the exact symptom profile, whether the patient reports pain while chewing, progressive facial weakness, or a total lack of oral moisture, clinicians can pinpoint exactly where the structural or systemic failure occurred. Physical examination through direct inspection is the first line of assessment. Confirming the actual pathology requires deploying specific diagnostic imaging based on the suspected failure. When dealing with a mechanical obstruction inside a duct, coelography is the diagnostic gold standard. In this diagram of a coelography procedure, a radio-opaque contrast dye is injected directly into an affected duct. On the X-ray, the flowing dye highlights the internal structure until it hits a dark void, visualizing the exact location of the calcified stone. That ductal dye technique is ineffective for investigating dense tissue masses located deep inside the gland itself. For those suspected masses, an ultrasound is deployed first to differentiate between a solid tumor mass and a fluid-filled cyst within the tissue. If a solid tumor is confirmed using that ultrasound or through a subsequent CT or MRI scan, performing a physical tissue biopsy is the final step to determine malignancy. Matching the anatomical symptom to the correct imaging modality ensures precise targeting and prevents delays in medical treatment. Translating all of this anatomical and diagnostic data into practice requires a clinical nursing approach, which we can organize here on our assessment matrix. The core nursing assessment relies on active observation. Nurses must monitor the patient's saliva flow rates, check for localized glandular swelling, and track systemic infection markers, such as fever. It requires a specific assessment of the patient's pain profile. You have to differentiate between a constant, localized ache that suggests an infection or tumor versus the sharp, acute pain that triggers during mastication, pointing to an obstructed duct. Once identified, targeted medical interventions begin. This involves administering prescribed antibiotics and pain relief while encouraging fluid intake to flush the ductal system. Physical interventions include applying warm compresses over the affected gland to stimulate ductal flow and relieve pressure. This is paired with maintaining strict oral hygiene protocols to prevent secondary infections. If conservative medical management fails to clear the pathology, nursing staff must prepare the patient for surgical intervention, ranging from targeted stone removal to the excision of the affected gland. Leaving these disorders untreated carries consequences. Localized blockages can progress into abscess formation or chronic infections, while expanding tumors can cause facial nerve damage and systemic dehydration. Preventing these complications requires a clinical approach that links microscopic architecture and cranial nerve mapping to the patient's observable symptoms.